Welcome back to the deep dive. Today, we're embarking on what I think is one of the most foundational and, frankly, most mysterious journeys in human biology. We're doing a deep dive into hematologic function. This unit, it covers the complexities of blood production, benign disorders and malignancies, and it touches every single patient you will ever encounter.
It really does.
It's the body's internal transport system, its defense force, and, the repair crew all rolled into one.
It is the great integrator. And the mystery you mentioned, I think it stems from the fact that, unlike, say, a heart attack or a broken leg.
Right, something obvious.
Exactly. It's not obvious. Hematologic issues often present silently or with such vague symptoms, things like fatigue or paleness, that we're heavily reliant on data, on lab reports to really confirm what's going on under the surface.
And that is the clinical hook right there. To ground us, let's start with a scenario that really puts the stakes into focus immediately.
Okay, picture this. You are working in an outpatient infusion center. A 66-year-old woman who is currently undergoing chemotherapy for non-Hodgkin lymphoma. She arrives for her treatment.
Okay.
But before she even gets settled, you notice she's just severely short of breath. Her heart rate is climbing, and when you check her pulse oximetry, it's reading a dangerously low 88% on room air.
Wow. Okay, that's a medical emergency. The chemo is immediately put on hold.
Absolutely. The workup confirms she is profoundly anemic. And this one patient, she just illustrates the three major clinical risks we are constantly managing in hematology.
The big three.
First, compromised oxygen carrying capacity, that's the anemia. Second, an increased risk of infection, due to low white cells, which can be linked to the chemo or the disease itself. And third, increased bleeding risk if her platelets are low.
And the text mentions this isn't an isolated incident.
No, not at all. Earlier that same week, another lymphoma patient had their treatment postponed because of a spiking fever, a classic sign of a neutropenic infection.
So when you're faced with these repetitive, really serious complications, anemia, infection, bleeding, it forces you to ask a pretty tough question, right?
It does.
Are these outcomes just unavoidable consequences of the cancer and its treatment? Or is there a systemic way we can actually improve care?
And that very question leads us directly into the systemic thinking framework we really need to talk about. It's the Quality and Safety Education for Nurses Competency, or QSEN, specifically on quality improvement.
Right. We can't just shrug and say, well, chemo always makes people anemic.
Yeah.
That's not good enough.
You need an actionable system for change. Let's unpack that QSEN definition here. So quality improvement, in this context, it means using data to monitor the outcomes of care-like or case study patients' severe anemia.
Exactly.
And then using formal methods to design and test changes. The goal is to continuously improve the quality and safety of the entire healthcare system.
Precisely. And for you, the nurse, this means you need to adopt certain attitudes, acquire certain knowledge, and develop specific skills. We call them the KSAs. So let's start with the K, the knowledge.
The knowledge component requires you to understand why measurement and variation are so important. So if 3 patients get severe anemia in one warrant, is that an acceptable variation? Or is that a sign of an outlier that demands scrutiny?
And the skill part, the S, that involves actually using that data.
Right. The skill is identifying data sources. Where do we get the HGB levels, the transfusion rates, the infection rates? And then you have to use established quality measures to benchmark your performance against, say, a national standard.
And maybe the hardest part is the A, the attitude.
Oh, absolutely. Because if you walk into that infusion center believing that anemia and infection are just inevitable outcomes of cancer treatment, you won't seek improvement.
You've already accepted it.
You have. The QSEN framework demands that we question that assumption. It forces us to set measurable objectives, like reducing the rate of severe, life-threatening anemia post-chemo by 10% in the next quarter, and then outlining the steps to achieve that change. It moves us from just being passive observers to active system improvers.
That sets our mission perfectly. So we are going deep into the foundational knowledge so you can recognize when things go wrong and understand the mechanism for improvement. Our roadmap today starts with Chapter 28, which is all about the anatomy, the physiology, and the crucial assessment techniques. Then we're going to tackle Chapter 29, the massive world of benign hematologic disorders, all the anemias, bleeding, and thrombotic issues.
And we'll finish up with Chapter 30, focusing on the hematologic malignancies, the leukemias, lymphomas, and multiple myeloma.
All right, let's get into it. Let's start at the very beginning with the foundation of the system. Chapter 28 introduces the hematologic system not just as blood, but as this complex fluid organ and its production facilities.
That's a really great way to put it. The hematologic system is, well, it's a specialized organ system that just happens to exist in a fluid state. It's composed of blood, that's plasma, and cells, making up about 7 to 9% of your total body volume.
Right.
The bone marrow, where all the cells are produced, and the reticuloendothelial system, or RES.
And the RES includes what? The spleen?
The spleen, lymph nodes, and the liver. They're responsible for cell breakdown and, immune surveillance.
And the production process itself, hematopoiesis, that's where all the potential problems really begin. It's like a continuous, highly regulated factory.
It is, and the concept of the primitive stem cell is absolutely critical here. These cells have this unique ability to self-replicate indefinitely, which ensures a lifelong supply. When they get a signal, they differentiate down two major irreversible pathways:
The myeloid and the lymphoid lines.
the myeloid stem cell line and the lymphoid stem cell line.
And why is that distinction so crucial in the clinic?
Because if a disease process, particularly a cancer like leukemia, affects that myeloid stem cell early on, it's going to disrupt the production of all three major cell lines:
All three.
red blood cells, platelets, and most of the white blood cells, your granulocytes and monocytes.
Huh.
The lymphoid stem cell line, on the other hand, it only produces the T and B lymphocytes. So knowing the line of origin tells us immediately which parts of the patient's system are going to be vulnerable.
Okay, so let's run through the essential components created by this factory, pulling the high-impact takeaways from Table 28-1 in the source material, starting with the primary defenders, the leukocytes.
All right, the neutrophils. They are the rapid response team. They're the primary defense against bacterial invasion, and they specialize in phagocytosis. But the crucial and often surprising fact here is their lifespan.
It's short, isn't it?
Incredibly short. They only circulate for about 6 hours before they migrate into tissues. So if you have a severe infection, the body just burns through its neutrophil supply incredibly fast. It can lead to neutropenia very, very quickly.
And the bone marrow is just working overtime to keep up.
Constantly.
And they're contrasted with the monocytes, which are, slower but more powerful?
Exactly. Monocytes circulate briefly, then they enter tissues to become macrophages. These are the heavy-duty, highly phagocytic scavengers. They're the second line of defense.
So they clean up the mess.
They do. They're really effective against fungi and viruses, and perhaps most importantly, they are responsible for tidying up. They digest aging cells, debris, and foreign material, and they're mainly concentrated in those RES organs like the spleen.
Okay, then we have the essential transport vehicle, the erythrocytes.
Your RBCs, or red blood cells, they have a 120-day lifespan and are essentially just bags of hemoglobin. Hemoglobin accounts for 95% of their cell mass.
Their only job is oxygen transport.
That's it. They're non-nucleated, super flexible, and designed to squeeze through the absolute smallest capillaries.
And the essential repair crew, the platelets.
Platelets, or thrombocytes, they are just granular fragments, and their production is regulated by a hormone called thrombopoietin. About 80% of them are circulating in the blood, while a key 20% are stored in the spleen.
And that splenic storage becomes really important later, right?
Very important when we start talking about disorders like thrombocytopenia. They initiate what's called primary hemostasis and are absolutely essential for forming that temporary plug at a site of injury.
Okay, focusing a bit more on RBC production erythropoiesis.
Yeah.
We need to remember this is a feedback loop that heavily involves a distant organ, the kidney.
It's a really elegant system. When the kidney detects hypoxemia or low oxygen tension in the blood, it releases the hormone erythropoietin.
EPO, for short.
Right, EPO. And this hormone acts directly on the bone marrow, stimulating it to just ramp up erythrocyte production. This entire process takes about a week, which is why when a patient becomes acutely anemic, the body can't just immediately fix it. It takes time to mobilize the forces.
And for this production line to be healthy, you need high-quality raw materials. And iron is the star of the show here.
Iron is absolutely indispensable for hemoglobin synthesis. It's stored in the liver, spleen, and bone marrow as a protein called ferritin, and it's transported through the blood by another protein called transferrin.
And when iron is deficient, what's the first thing we should think of?
If we're looking at an adult male or a postmenopausal woman, we must assume it's due to chronic blood loss, not poor diet.
It's a bleed until proven otherwise.
A bleed until proven otherwise, and when you're low on iron, hemoglobin synthesis just slows way down.
And what visual signs does that create in the cells themselves? What do they look like?
The resulting red cells are visibly abnormal. They're smaller than normal, which we call microcytic, and they are pale because they lack sufficient hemoglobin, which makes them hypochromic.
Microcytic hypochromic.
That morphology is a diagnostic giveaway. It's a mandatory rule. An adult diagnosed with new-onset iron deficiency must be immediately investigated for a hidden source of bleeding, most commonly from the GI tract, maybe a slow leak from a colon cancer.
And while iron dictates the size and color, what role do vitamin B12 and folate play?
They are critical for the rapid normal DNA synthesis required by these highly proliferative cells. If you lack B12 or folate, the resulting cells are defective. They are abnormally large. We call them megaloblasts.
Huge.
Huge. And many of them die right there in the bone marrow before they can ever even enter circulation. This ineffective production is the hallmark of megaloblastic anemia.
Okay, let's move from production to stopping bleeding. Hemostasis. This is a highly regulated two-phase process.
Phase 1 is primary hemostasis. That's the platelets sticking to the injured vessel wall and clumping together to form a temporary platelet plug. Phase 2 is secondary hemostasis, which is the complex coagulation cascade that stabilizes that plug.
Let's break down that coagulation cascade because it can get pretty dense. We have the intrinsic and extrinsic pathways, and they converge into a common pathway. For the listener, what's the fastest path and why?
So the fastest path is the extrinsic pathway, or the tissue factor pathway. It's the quick response pathway activated when you suffer external trauma and your tissue gets damaged.
A cut, for example.
A cut, exactly. Injured tissue releases something called thromboplastin, or tissue factor, which quickly initiates the cascade. Think of the extrinsic pathway as the body's trauma response. It needs to work fast.
And the intrinsic pathway.
The intrinsic pathway, or contact activation pathway, is slower. It's activated when the inner lining of the blood vessel, the collagen, is exposed. This is often associated with internal damage or inflammation, like plaque buildup and atherosclerosis.
And they both end up in the same place.
Both pathways eventually merge into the common pathway, which converts prothrombin to thrombin and then fibrinogen to that stable fibrin mesh that locks the clot into place.
Okay, here's where the technical detail immediately translates into a crucial nursing responsibility. Which pathway do our common lab tests target?
Excellent point. We monitor the extrinsic pathway using the prothrombin time, or PT, and its standardized measure, the INR.
The International Normalized Ratio.
Right. And this is the test we use to monitor patients on the oral anticoagulant warfarin. Conversely, we monitor their intrinsic pathway using the activated partial thromboplastin time, or APTT. That's the test we use when we're managing intravenous heparin therapy. Understanding that linkage is absolutely essential for safe drug administration.
Finally, we can't forget the cleanup crew. Once the vessel is repaired, we need fibrinolysis.
Fibrinolysis is just the natural clot dissolution process. The key enzyme is plasmin. Plasminogen gets incorporated into the clot as it forms, and when signals indicate the clot is no longer needed, it's converted to plasmin, which then just systematically digests the fibrin mesh. This mechanism prevents our bodies from being clogged up with old clots.
Before we move on to patient assessment, what specific vulnerabilities do we see in our older adult population?
Gerontologic considerations are really vital here. We see a diminished functional capacity in the bone marrow. So when an older patient needs new blood cells, maybe because of sudden blood loss or an infection, their bone marrow often responds slower and less robustly.
Right.
This leads to a higher propensity for leukopenia or chronic anemia. Furthermore, there's a decline in T and B cell development, what we call immunosenescence, which makes them more susceptible to infectious diseases and potentially certain malignancies.
So when we approach the patient, the assessment begins with the health history, and the genetic element just looms large.
The nurse has to become a detective here. Because of the high prevalence of inherited disorders, from X-linked hemophilia to autosomal recessive sickle cell disease to autosomal dominant factor V Leiden, a detailed family history, ideally spanning 3 generations, is mandatory.
And you need a good nutritional history too.
Exhaustive. Are they vegetarian? Do they drink alcohol? And a precise medication list, including over-the-counter supplements, because so many common drugs, even NSAIDs, impact coagulation.
If we look across all hematologic disorders, what is the one red flag symptom that should trigger an immediate investigation?
It's overwhelmingly extreme fatigue. This is the single most common symptom cited across the entire spectrum of anemia and many malignancies. It can often be dismissed as just getting older or stress, which is why linking it to objective lab data is so critical.
Okay, let's look at the external signs, the physical assessment findings from Table 28.2, starting with the skin.
Skin color can tell a powerful story. If you see a gray tan or bronze skin color, particularly in areas exposed to the sun or, the genitalia, this strongly suggests hemochromatosis. That's the deposition of excess iron.
And the opposite.
The opposite would be a deep ruddy or plethoric complexion redness in the face, conjunctiva, hands and feet. That can indicate polycythemia vera, where the patient has an excess volume of red cells, making the blood visibly thick.
And what about the subtle signs of bleeding?
We look for ecchymoses, bruises, but if we see petechiae, those tiny, non-blanching, pinpoint red or purple hemorrhagic spots, usually on the trunk or lower legs, that's a severe warning sign. It often indicates profound thrombocytopenia, where the platelets are just insufficient to maintain vascular integrity.
The oral cavity provides some essential clues, too.
Definitely. Jaundice visible on the soft palate suggests hemolysis, but you have to pay attention to the tongue. A smooth, red, often glossy tongue can be a sign of iron deficiency. A beefy red tongue with significant inflammation is highly characteristic of B12 or folate deficiency. And certain leukemias, particularly AML, can cause remarkable enlargement or hyperplasia of the gums.
Finally, the neurological system. It reveals the unique danger of one specific deficiency.
Yes, B12 deficiency. Unlike iron or folate deficiency, B12 deficiency pernicious anemia attacks the nervous system. We must assess for paresthesias, that's the tingling and numbness, ataxia, which is difficulty balancing or walking, and a loss of position sense or proprioception. These are critical findings because they can become progressive and permanent if they're left untreated.
Since we are so reliant on data, let's detail the diagnostics. Everyone knows the complete blood count, the CBC, but it's the peripheral blood smear that often solves the mystery.
Right, the CBC gives us the numbers, the counts of the cells, the amounts of hemoglobin and hematocrit, but the peripheral blood smear is the clinician actually looking at the cells under a microscope. It provides the essential information on cellular morphology.
Their size, shape, appearance.
Exactly. You can see the microcytic hypochromic cells of iron deficiency, the large megaloblasts, or the distinctive sickled cells. It's what links the quantitative data to the qualitative pathology.
We mentioned the coagulation tests earlier, PTINR and APTT. What about the procedure that confirms the factory's status, the bone marrow exam?
This is often the definitive test for serious hematologic conditions like leukemia or aplastic anemia. It involves two parts, often done sequentially: an aspiration, which is drawing out liquid cellular material, and a biopsy, which is coring out a small piece of solid tissue.
And in adults, the site is almost always the iliac crest in the hip.
The posterior superior iliac crest, yes.
This procedure is understandably intimidating for patients. What is the essential patient education regarding the experience?
Clear communication is everything for reducing anxiety. We explain that while the skin and soft tissue are anesthetized, the bone itself, the periosteum, is only partially dulled. The patient will feel intense, pushing pressure as the needle is advanced through the bone.
And the pain.
The single moment of sharp, severe, but very brief pain occurs during the aspiration, when the marrow fluid is suctioned out. For the biopsy, they should feel significant pressure and a deep ache, but generally not that sharp, brief pain of the aspiration. Encouraging deep, rhythmic breathing is vital to help them through those short, painful moments.
And the post-procedure care has to focus on minimizing the two main risks.
Bleeding and infection. Pressure must be held on the site for several minutes, and a sterile pressure dressing is applied. The patient should lie on their back or side for up to an hour to maintain that pressure. And key patient education. Mild analgesics like acetaminophen are fine, but aspirin-containing products or NSAIDs must be strictly avoided for the first day or two.
Because they inhibit platelet function.
They do, and that increases bleeding risk. We also caution against any rigorous activity or contact sports for a day or two.
All right, let's turn to the active treatments, starting with a surgical intervention, the splenectomy.
The spleen, as part of the RES, is a highly vascular organ. It's the major site of macrophage activity and cell destruction. So if a patient is suffering from a condition where their blood cells, RBCs, WBCs, or platelets are being excessively destroyed or trapped in the spleen, surgical removal can be curative or at least profoundly helpful.
And you see this in ITP.
Often in severe immune thrombocytopenic purpura, ITP, or certain hereditary hemolytic anemias.
The nursing imperative here relates to the long-term consequence of living without a spleen.
It is a profound, lifelong risk of severe, overwhelming infection, particularly from encapsulated bacteria like pneumococcus, meningococcus, and Haemophilus influenza.
So vaccination is key.
It's non-negotiable.
Yeah.
The crucial nursing role is to ensure these patients are vaccinated, ideally before the surgery, against these organisms, and they need their routine flu shots. They must be educated that any sign of infection, no matter how minor, requires immediate medical attention for the rest of their lives.
Okay, next, the intervention that carries the highest risk and requires the most scrutiny. Blood transfusions. Chart 28-3 details the necessary step-by-step vigilance.
The process is meticulous by necessity. The pre-transfusion assessment includes their history, any prior reactions, how many times they've been pregnant, because repeated fetal exposure can create antibodies, and establishing a baseline fluid status.
Why is that baseline fluid status so important?
Because the primary risk, especially in older patients or those with cardiac or renal failure, is fluid overload. We must check the lungs for crackles and assess for jugular venous distension or JVD. If we see signs of hypervolemia, we often need a provider order to give a diuretic before or during the transfusion to prevent TACO.
TACO, transfusion-associated circulatory overload.
Exactly.
Then comes the moment of truth, verifying the product.
This is the single most critical safety check to prevent that fatal acute hemolytic reaction. There must be a 2RN verification check at the patient's bedside.
2 nurses every time.
Every single time. They must compare the blood bank label with the patient's ID wristband, confirming name, date of birth, patient ID number, and making sure the ABR type matches what was ordered. The nurse also has to inspect the product for discoloration, gas bubbles, or clumps, which might indicate bacterial contamination.
And during the infusion, monitoring is key.
We get vital signs immediately before starting. The first 15 minutes are the most crucial. If a severe acute hemolytic reaction is going to occur, it happens very quickly. We infuse slowly during that window, then check vitals again, and then typically every 30 minutes after that. And we have to remember to change the administration tubing after every 2 units of packed red blood cells.
Okay, let's detail the major complications, starting with the most common and moving to the 2 most life-threatening. The most frequent is the febrile non-hemolytic reaction.
Right. This is characterized by a temperature rise, a fever of 1 degree Celsius or more, and chills. It usually happens toward the end or shortly after the infusion. It's believed to be caused by antibodies attacking residual donor white cells.
And this is preventable.
The great takeaway here for quality improvement is prevention. These reactions can often be prevented by using leukocyte reduction filters to remove those residual white cells before the transfusion ever starts.
The other common, but less dangerous reaction is the allergic reaction.
This one manifests as urticaria hives or generalized itching, usually due to a sensitivity to plasma proteins. If the symptoms are mild, we stop the transfusion, give an antihistamine like diphenhydramine, and if the symptoms resolve and the provider approves, we may resume the transfusion at a slower rate.
Okay, now the dangerous ones. Start with the most immediate threat. Acute hemolytic reaction.
This is the deadliest reaction. It's caused almost exclusively by ABO incompatibility, which usually results from human error.
A clerical mistake? Wrong patient ID?
Yes. And it triggers massive intravascular hemolysis. The symptoms are dramatic and terrifying, often starting with a feeling of dread, followed by fever, chills, low back pain right where the kidneys are, chest tightness, and the definitive sign, hemoglobinuria. Blood in the urine as the destroyed RBC components pass through the kidneys.
What do you do?
You stop the transfusion immediately. Keep the 5-line open with saline and notify the provider. It's an all-hands-on-deck emergency.
The other life threat we discussed is TACO.
Transfusion-associated circulatory overload. This is purely a volume problem. If the blood is infused too rapidly, it just overwhelms the patient's circulatory capacity.
And the symptoms mimic acute heart failure.
They do. Severe dyspnea, sudden onset of crackles in the lungs, a bounding pulse, JVD, and tachycardia. Immediate nursing intervention. Stop the infusion, place the patient upright with their feet dependent to reduce venous return, and give prescribed diuretics promptly.
Finally, what about the risk of infection from bacterial contamination?
This is why packed red cells and whole blood have that strict 4-hour administration limit. If it takes longer, the risk of bacterial proliferation leading to sepsis is just too high. Symptoms of fever, chills, and profound hypotension may be delayed, sometimes for hours after the transfusion.
And the treatment?
You'd have to stop the blood immediately, give aggressive fluid resuscitation, and start broad-spectrum IV antibiotics.
That intensive safety discussion leads us to a crucial ethical consideration described in the text. The case of LC, the 76-year-old intubated ICU patient needing blood.
Yeah. This scenario perfectly illustrates the tension between autonomy, beneficence, and legal authority. Elsie is severely anemic, her HGB is 7.7, and she needs a transfusion. Her parents, who are her legally designated surrogates, object because they are Jehovah's Witnesses and oppose blood transfusions.
But her boyfriend, who has no legal authority, states that Elsie stopped adhering to that religion years ago.
Right. And since Elsie lacks capacity and has no advance directives, her parents' decision must legally prevail. But what's the moral consideration?
That's the conflict.
The clinical team has to prioritize Elsie's potential autonomy. The law requires us to follow the surrogate's decision, but our ethical obligation is to determine what Elsie would have wanted. This means mobilizing ethics committees, legal counsel, and social workers to interview everyone who knew Elsie intimately, including the boyfriend, to try and determine her most recent wishes regarding blood products. It's a profound conflict, often forcing the clinical team to seek a court order if the medical necessity is paramount and the patient's current desires are genuinely uncertain.
Moving into Chapter 29, we're focusing on anemias. We established earlier that anemia is not a disease itself, but a sign, the most common hematologic disorder, signaling a deficiency in oxygen-carrying capacity.
And the first step in management is classification, which is generally based on the underlying mechanism. You can see this in Table 29-1. We look at whether the bone marrow is failing to produce cells or if the cells are being destroyed too quickly.
So describe the failure to produce the hypoproliferative anemias.
These are defined by decreased production. They're characterized by a low, or what we call an inappropriately normal, reticulocyte count.
What's a reticulocyte again?
Reticulocytes are young, immature red cells. They're a good indicator of the bone marrow's current output. So if a patient is anemic, meaning they have a low HGB, but the reticulocyte count isn't high, the bone marrow is basically sleeping on the job.
And that points to what kind of problems?
That points to deficiencies like iron, B12, or folate, or maybe renal disease, or even aplastic anemia.
Conversely, if the bone marrow is wide awake and frantically trying to keep up, we're looking at hemolytic anemias.
Correct. Hemolytic anemias involve increased destruction of RBCs. The body recognizes the hypoxia and floods the system with erythropoietin, which leads to a high reticulocyte count. Clinically, we also see elevated indirect bilirubin from all that RBC breakdown and decreased haptoglobin, which is a protein that binds free hemoglobin.
And causes there would be things like sickle cell disease.
Intrinsic defects like sickle cell or extrinsic issues like mechanical heart valves just shearing the cells apart.
And the severity of the patient's symptoms isn't just about how low the hemoglobin is, but how quickly it drops.
Absolutely. The body is amazing at compensation. If a patient loses 50% of their hemoglobin gradually over 6 months, they might only report profound fatigue and maybe a slight tachycardia during intense exercise. Their body has adapted.
How so?
By increasing heart rate, extracting more oxygen from existing RBCs, and shifting fluid around. But a rapid 30% loss, like from a GI bleed, leads to shock, profound hypotension, and vascular collapse because the body just can't compensate fast enough.
What are the severe complications nurses always have to watch for, especially in the vulnerable elderly?
Cardiac decompensation, particularly heart failure, as the heart works harder and faster to circulate inadequate oxygen. In older adults, we also see neurological issues, confusion, delirium, and impaired cognitive function due to cerebral hypoxia.
So from a global nursing management perspective, what are our cornerstones of care?
First, you have to correct the cause. Stop the bleed, replace the nutrient. Second is supportive care. We need volume replacement IV fluids or transfusions for acute loss. We provide supplemental oxygen to ease the strain on the cardiopulmonary system, and we have to aggressively monitor for signs of heart failure.
So daily weights.
Daily weights, checking IO, looking for JVD, crackles, and peripheral edema. And nutritional counseling is always key, focusing on B12, folate, and iron.
Okay, let's look closer at specific hypoproliferative types, starting with iron deficiency anemia, the most common type globally.
We already defined it, microcytic and hypochromic cells. Diagnosis is confirmed by the trifecta of lab values: low serum ferritin, which means low stores, low serum iron, and an elevated total iron binding capacity, or TIBC.
And the TIBC is high because
It's the body signaling. It has lots of open spots on its transport proteins to carry iron, but there's no iron available to carry.
this is where patient education becomes so challenging, right? Because of adherence issues. Oral iron supplements often cause terrible GI side effects.
They really do. We recommend taking ferrous sulfate 1 hour before or 2 hours after meals for optimal absorption. However, if the patient is vomiting or just can't tolerate it, taking it with food is permissible, even though it slightly reduces absorption.
And what are the critical teaching points from the chart?
Vitamin C, like in a glass of orange juice, significantly enhances absorption. And patients must be warned that their stool will turn dark, often black. This is normal, but they have to be able to distinguish that from potential melena, which is bloody stool, and constipation management high fiber stool softeners is often required.
Now, the megaloblastic anemias, defined by those large defective cells. Let's focus on vitamin B12 deficiency, often due to pernicious anemia.
Pernicious anemia means the patient lacks something called intrinsic factor, or IF. It's secreted by the gastric mucosa and is absolutely necessary for B12 absorption in the small intestine. This is typically an autoimmune disease that attacks those gastric cells.
And the critical clinical point here is the neurology.
Yes, the unique and severe neurological manifestations. Paresthesias, gait disturbance, difficulty sensing vibration and position. These neurological deficits are irreversible if treatment is delayed too long.
So management here has to bypass the faulty GI tract entirely.
Yes. Since the problem is absorption, not necessarily intake, we treat with lifelong B12 replacement. Traditionally, that's monthly intramuscular injections. High-dose daily oral B12 has also been shown to be effective, as a tiny amount can still be absorbed passively without IF.
And there's a long-term risk to educate them on.
A crucial one. Because this condition is associated with severe gastric atrophy, these patients have an increased lifetime risk of developing gastric cancer, so they need consistent screening.
Finally, aplastic anemia, the dramatic failure of the bone marrow.
This is bone marrow failure leading to pancytopenia, low everything. The likely cause is an immune-mediated mechanism where T cells mistakenly attack and destroy the hematopoietic stem cells. The diagnostic giveaway is the bone marrow biopsy itself.
What does it show?
The marrow is hypoplastic, meaning sparse cells, or even aplastic, replaced almost entirely by fat.
This leads to profound vulnerability.
It does. The treatment pathway depends on age and health. For younger patients, generally under 60, the goal is a cure via a hematopoietic stem cell transplant, or HSCT. For older or sicker patients, it's immunosuppressive therapy, often involving antithymocyte globulin, ATG, to stop the T cells from destroying the stem cells. These patients face a massive risk of death from overwhelming infection and hemorrhage.
Shifting to disorders where the cells are produced but destroyed prematurely. The exemplar here is sickle cell disease, SCD, a disorder that requires some of the most complex specialized nursing care in all of hematology.
SCD is genetic, and it causes the production of an abnormal hemoglobin S, or HbS. When this HbS is deoxygenated, the red blood cells lose their flexible shape and become rigid and sickle-shaped.
And these rigid cells are sticky.
Very sticky. They adhere to the walls of the microcirculation, creating a traffic jam of vascular occlusion. This leads to tissue hypoxia, ischemia, and eventually necrosis.
The complications are systemic, hitting virtually every organ. Beyond the chronic anemia and jaundice from hemolysis, what are the acute threats?
The most common and agonizing event is the vaso-occlusive crisis. It's severe, acute pain due to blocked blood flow, often triggered by dehydration, cold, or stress. The pain is debilitating and requires aggressive, high-dose opioid and non-opioid management.
And the life-threatening respiratory complication is acute chest syndrome.
Acute chest syndrome, or ACS, is a medical emergency. It often follows a vaso-occlusive crisis or an infection and presents with new pulmonary infiltrates, chest pain, and fever. It's essentially a pulmonary infarction or a severe pneumonia, and it can rapidly lead to respiratory failure.
And it requires aggressive oxygenation and often exchange transfusions.
Absolutely. We also need to consider the neurological impact. The stroke risk is high, particularly ischemic stroke. But what is often overlooked are the silent cerebral infarcts. These are small, repeated blockages in the brain that don't cause acute symptoms but accumulate damage over time, leading to significant progressive neurocognitive decline and learning disabilities, especially in children.
And prophylactic transfusions are often used to prevent that damage.
Right, to keep the percentage of HbS low.
How do nurses manage pain in a crisis situation, and what is the critical intervention guideline?
Pain management has to be prioritized, often using PCA pumps or large doses of opioids because sickle cell pain is generally resistant to standard dosing. Aggressive hydration, either IV or oral, 2 to 3 liters daily, is essential to maximize blood flow and reduce viscosity.
And the critical alert?
The critical alert is that you must avoid cold packs and ice.
Why is that?
Cold causes vasoconstriction and can immediately precipitate further sickling, making the crisis worse. We use warmth and relaxation techniques instead.
Let's do a quick note on hereditary hemochromatosis, the disorder of iron overload.
Right. This is a genetic condition where the GI tract absorbs excessive amounts of iron, which then gets deposited in vital organs, the liver, heart, pancreas causing damage, and organ failure. The treatment is kind of counterintuitive and ancient.
Therapeutic phlebotomy.
Therapeutic phlebotomy. We regularly remove 500 milliliters of blood until the hematocrit and ferritin levels return to normal. It's the mainstay of treatment. Patients also have to manage their diet, avoiding iron-rich foods, supplemental iron, and alcohol due to its toxicity to their iron-laden liver.
Okay, switching focus to the disorders of platelets and coagulation factors. Let's start with thrombocytopenia, low platelet counts, and the threshold for danger.
So platelet counts start signaling a risk for spontaneous bleeding when they drop below 50,000. The truly dangerous zone where you can have a spontaneous, potentially fatal CNS or GI bleed is below 5,000 to 10,000.
And counts below 20,000 often trigger prophylactic platelet transfusions.
That's right.
One common cause is immune thrombocytopenic purpura, or ITP.
ITP is an autoimmune disease where the body produces antibodies that coat and destroy otherwise healthy platelets. The treatment goal is just to get a platelet count high enough to prevent serious bleeding, usually above 20,000 to 30,000.
And how do you treat it?
First-line treatment is often high-dose corticosteroids to suppress the immune system, then maybe IV immunoglobulin, IVIG, if needed, or in chronic refractory cases, a splenectomy to remove the primary site of platelet destruction.
The nursing safety education for a thrombocytopenic patient, detailed in Chart 29-8, is essential for their survival.
It's all about preventing trauma and shear forces. This means using an electric razor only, a soft bristle toothbrush to avoid gum bleeding, and avoiding rectal procedures or medications.
Right.
Patients must avoid straining during defecation, aggressive coughing, or vomiting, as these all increase intracranial pressure and bleeding risk. And they must strictly avoid drugs that impair platelet function, like aspirin and NSAIDs.
Turning to inherited coagulation defects, hemophilia A and B.
Hemophilia A is a factor VIII deficiency, and hemophilia B is a factor IX deficiency. They're X-linked, meaning they predominantly affect males. The bleeding is often deep and painful into joints, which we call hemarthrosis, causing permanent damage or large muscle hematomas.
And management is all about replacing the missing factor.
Exactly. Replacing the deficient factor, often via prophylactic infusions several times a week, avoiding injections and invasive procedures, and giving immediate factor replacement upon any traumatic event.
And von Willebrand disease, the most common inherited bleeding disorder.
VWD affects both genders and involves a deficiency or defect in the von Willebrand factor. This factor is required for platelet adhesion, and it also carries factor VIII. So because platelets are affected, the bleeding is generally mucosal.
So, nosebleeds, heavy menses.
Frequent nosebleeds, heavy menses, GI bleeding. Treatment for type 1, which is the most common, is often desmopressin, or DDAVP, which temporarily raises the level of VWF and factor VIII.
We have to discuss disseminated intravascular coagulation, or DIC, the catastrophic bleeding and clotting paradox.
DIC is a systemic syndrome. It's never a primary diagnosis. It's triggered by profound shock, sepsis, trauma, or cancer. The pathophysiology is terrifying.
How so?
There is massive unregulated activation of the clotting cascade, leading to widespread microthrombosis, tiny clots everywhere, which consumes all the available platelets and coagulation factors.
And once all the resources are used up,
the patient crashes into massive frank hemorrhage.
so the patient is simultaneously clotting inappropriately and bleeding uncontrollably. What are the key warning signs?
An early sign is a progressive, unexplained drop in platelet count and a rising D-dimer, which is a marker of fibrinolysis. Later signs include both thrombosis-like cyanosis and decreased pulses and hemorrhage oozing from IV sites, petechia, and intracranial bleeding.
Given that complexity, what is the core nursing priority for DIC management?
Treating the underlying cause. If the patient has septic shock, that must be addressed aggressively first. Until the trigger is stopped, the DIC process will just continue, regardless of how much you transfuse. Supportive care involves replacing factors and platelets for active, severe hemorrhage and meticulous management of skin and oral integrity to prevent new bleeding sites.
Finally, the flip side, thrombotic disorders or hypercoagulability.
These are conditions where the body clots too easily. A classic example is the factor V Leiden mutation, the most common inherited cause of venous thrombosis in Caucasians. Others include deficiencies in natural anticoagulants like protein C or S. Management is focused on lifelong anticoagulation and crucial lifestyle modifications,
Like,
avoiding long periods of immobility, stopping smoking, and avoiding high-risk estrogen-containing contraceptives.
our final section dives into Chapter 30, the hematologic malignancies disorders stemming from the clonal proliferation of an abnormal hematopoietic stem cell.
And leukemias are classified by the speed of progression, so acute versus chronic, and the cell line of origin, myeloid versus lymphoid.
Acute leukemias involve rapid proliferation of immature cells, the blasts, while chronic leukemias involve the gradual accumulation of mature but often non-functional cells.
Exactly.
So let's start with acute myeloid leukemia, AML, the most common acute leukemia in adults.
AML involves the uncontrolled proliferation of abnormal, non-functional myeloid blast cells, which rapidly crowd out normal hematopoiesis. The patient's clinical signs are entirely a result of this crowding, leading to pancytopenia.
So profound fatigue from anemia.
Life-threatening infection from neutropenia and bleeding from thrombocytopenia. Other signs include that gum hyperplasia we mentioned and bone pain due to marrow expansion.
The initial treatment, induction chemotherapy, is an intense, deliberate act of destruction.
It is. Induction chemo is highly toxic, aiming to wipe out the leukemic cells. But it causes profound myelosuppression, which means the patient's absolute neutrophil count, their ANC, will likely drop to near zero for weeks. This is the period of highest risk, requiring weeks of strict protective isolation in the hospital, prophylactic antifungals, antivirals, and meticulous care for severe side effects like mucositis.
The massive sudden destruction of these cells creates the oncologic emergency we have to prevent. Tumor lysis syndrome, TLS.
TLS is a life threat caused by the explosive rupture of millions of cells, which releases their intracellular contents rapidly into the bloodstream. This creates a chemical storm.
What's in the storm?
High potassium, risking fatal arrhythmias, high phosphate, and high uric acid, which risks acute kidney injury due to crystallization. Prevention is key. Aggressive hydration to flush the kidneys and using medications like allopurinol or resburicase to lower those uric acid levels.
Okay, moving to chronic myeloid leukemia, CML, which has really seen a revolution in treatment.
It has. CML is characterized by a specific genetic mutation, the Philadelphia chromosome translocation, which creates the abnormal BCR-ABL protein. CML progresses through chronic, accelerated, and eventually blast crisis phases.
And the revolution came with targeted therapy.
Tyrosine kinase inhibitors, or TKIs, like imatinib, Gleevec, and nilotinib. These are miracle drugs. They specifically target that BCR-ABL protein, transforming CML from a death sentence into a manageable chronic condition.
But there's a huge nursing challenge here.
A huge one. TKIs are oral agents taken at home. Studies show adherence rates are alarmingly low, sometimes as low as 51% because of challenging side effects like fatigue, generalized edema, and potential cardiotoxicity. The nurse's role in education and adherence support is absolutely paramount for long-term survival.
Next, acute lymphocytic leukemia, AL.
AL involves immature lymphoid cells. It's characterized by its high propensity to infiltrate organs outside the bone marrow, specifically the central nervous system, the CNS.
So treatment has to get into the brain.
It does. It has to include agents that cross the blood-brain barrier, like intrathecal chemotherapy, to prevent a devastating relapse in the CNS. Treatment often includes intense chemo, corticosteroids like dexamethasone, and increasingly cutting-edge cellular therapies like CRT cells.
And chronic lymphocytic leukemia, CLL, the most common adult leukemia.
CLL is the slow, progressive accumulation of mature but immunologically incompetent lymphocytes. Many patients are diagnosed incidentally and are initially monitored with watchful waiting.
But then you look for B symptoms.
The development of B symptoms, unexplained fever, drenching night sweats, weight loss from chart 31, is the classic indicator that the disease is worsening. The major long-term issue for these patients is severe recurrent infection because their B lymphocytes fail to produce functional antibodies. They often require regular IVG replacement therapy.
Let's consolidate the overarching nursing management for all acute leukemias, integrating the lessons learned about myelosuppression.
Right, the nursing process is really centered around meticulous prevention and symptom control.
First, infection control.
Strict neutropenic precautions. Focus on hand hygiene, clean rooms, ensuring cooked food only, and avoiding unnecessary exposure.
Bleeding risk management.
Monitoring platelet counts, avoiding IM injections, and using soft-touch patient care.
And managing mucositis and pain.
Chemotherapy just destroys rapidly dividing mucosal cells. Oral assessment is continuous. We provide frequent oral care, prescribed mouthwashes, and utilize PCA pumps for systemic pain management because mouth pain can be excruciating enough to limit nutrition and hydration.
Then there's the fatigue.
Severe and persistent. We have to balance rest with gentle activity to prevent deconditioning and use strategies like HEPA filter masks to allow neutropenic patients to ambulate outside their rooms safely.
And finally, fluid and electrolyte balance.
Constant monitoring of intake and output and aggressive replacement of common electrolyte deficits like potassium and magnesium, which are often depleted by chemotherapy agents.
Okay, moving from aggressive leukemias to two families of clonal myeloid disorders that don't always meet the criteria for frank cancer, but carry significant risks. First, myelodysplastic syndromes, or MDS.
MDS is the condition of ineffective hematopoiesis. The bone marrow is actually hypercellular, it's busy producing cells, but the cells are defective and die before they can even leave the marrow. The result is peripheral cytopenias, low counts in the circulating blood.
And it's considered a pre-leukemic condition.
With a high chance of transforming into AML, yes.
What is the massive management complication for chronic MDS patients?
Iron overload. Because MDS patients are often dependent on frequent red blood cell and platelet transfusions for supportive care, they accumulate massive amounts of excess iron. This iron deposits in the heart, liver, and endocrine organs, eventually causing dysfunction and failure.
And this has to be managed proactively.
With iron chelation therapy, like Defer-SROX, to bind the iron and excrete it.
Next, the myeloproliferative neoplasms, or MPNs, starting with polycythemia vera, PV.
PV is the primary MPN characterized by an increased volume of red blood cells, leading to a high hematocrit, often over 55%. The symptoms are directly related to hyperviscosity. The blood is just too thick, it's sludgy.
So they get headaches, dizziness.
Severe headaches, dizziness, blurred vision, and they often have that characteristic ruddy or plethoric complexion. Another distinguishing symptom is debilitating generalized pruritus or itching, often strangely triggered by contact with water. We call it aquagenic pruritus.
What is the cornerstone of PV treatment?
Therapeutic phlebotomy. We deliberately draw off 500 milliliters of blood once or twice weekly until the hematocrit is safely below 45%. This blood loss not only reduces cell volume, but it also induces a state of iron deficiency, which the abnormal bone marrow needs to slow down the production of new cells.
And low-dose aspirin is used as well.
To prevent thrombotic events, yes. Nursing care really centers on managing the persistent fatigue and the chronic pruritus, recommending tepid water baths and emollients.
And essential thrombocythemia, ET.
ET is characterized by an excessive production of megakaryocytes, leading to very high platelet counts, often over 1 million. The main complications are either microvascular thrombosis or clots, or paradoxically, hemorrhage. Management often involves low-dose aspirin and cytoreductive therapy like hydroxyurea to keep the platelet count controlled.
Finally, we address malignancies of the lymphoid and plasma cell lines, starting with the lymphomas. Hodgkin and non-Hodgkin.
Hodgkin lymphoma, or HL, is distinguished by the presence of the characteristic Reed-Sternberg cells. HL is often localized to a specific node region and, crucially, has one of the highest cure rates in oncology, around 90% when treated with combination chemotherapy, like ABVD and ARTER radiation.
In non-Hodgkin lymphoma, NHL is far more heterogeneous and complicated.
It is. NHL is highly diverse, and unlike HL, for many NHL subtypes, the goal is often long-term remission rather than an outright cure. The aggressive subtypes carry a high risk of tumor lysis syndrome, and because of the use of highly specific biologic agents, nurses have to be vigilant for rare but fatal complications like progressive multifocal leukoencephalopathy, or PML,
which is
an opportunistic viral infection of the brain that presents with confusion and motor weakness.
We conclude with multiple myeloma, MM, the malignancy of antibody-producing plasma cells.
MM is primarily a disease of older adults where malignant plasma cells rapidly accumulate in the bone marrow. They produce large amounts of a useless protein called M protein. The key clinical manifestations are often summarized by the classic mnemonic CRAB features.
Okay, walk us through the CRAB features because these dictate acute management priorities.
C is for hypercalcemia. The aggressive plasma cells secrete factors that dissolve the bone, releasing excessive calcium into the blood, leading to confusion, dehydration, and arrhythmias. R is for renal dysfunction, which affects about a third of patients because the M protein damages the kidney tubules. A is for anemia, due to the plasma cells crowding out the normal production of red blood cells.
And B.
And B is for bone destruction, which causes agonizing bone pain, often back pain or rib pain, and a high risk of pathological fractures and spinal cord compression.
So management has to attack the cancer while also mitigating the bone destruction.
Yes, we use complex, multi-agent chemotherapy regimens, often including highly specialized drugs like proteasome inhibitors and immunomodulatory drugs. And to manage the hypercalcemia and bone destruction, bisphosphonates like pamidronate are standard. They slow down the bone destruction process.
What are the primary nursing responsibilities here?
We prioritize pain control, ensuring effective analgesia. We manage hypercalcemia through aggressive hydration, often requiring 3 to 5 liters of fluid per day. And crucially, we must address peripheral neuropathy, which is a common disabling side effect of many of the new targeted drugs. Nurses have to routinely assess gait and sensation, ensuring the patient has home safety measures in place to prevent falls. This has been an incredibly comprehensive look at hematologic function, connecting the basic anatomy of the stem cell all the way through to the management of these complex malignancies.
It has.
And I think the central synthesis is that all hematologic disorders, whether they're benign or malignant, ultimately funnel down into the same high-stakes nursing management areas.
It all comes back to managing the consequences of bone marrow failure or overactivity. The constant requirement for the nurse is just meticulous attention to detail in infection prevention, vigilant management of bleeding risk, and comprehensive symptom control across pain, fatigue, and nutritional status.
And as we discussed, the field is rapidly moving toward highly potent, targeted oral agents. We saw that with the TKIs for CML and the complex regimens for multiple myeloma. This technological leap places a new, and I think profound, responsibility on the nurse.
Which leads us to our final provocative thought for you, the learner, to carry forward. Considering the sheer power and specificity of these new oral therapies and the necessity of managing their challenging side effects, what is the single greatest non-pharmacological intervention a nurse can provide to ensure a patient battling a chronic hematologic malignancy achieves optimal long-term survival?
We talked about how challenging adherence is in CML, and the answer is just relentless, tailored, and comprehensive adherence support and education.
It's all about the follow-through.
It is. If the patient doesn't take the oral agent exactly as prescribed, the drug doesn't work, and the disease progresses. The nurse's ability to build trust, to simplify complex dosing schedules, to troubleshoot side effects, and provide tailored education, especially for older adults navigating multiple comorbidities, is often the decisive factor between remission and relapse.
The nurse is the lifeline that connects the complex science to the patient's daily reality. Thank you for taking this deep dive with us today. We hope you feel thoroughly equipped to approach this system with precision and confidence.
We appreciate you investing your time in learning these crucial details.
Until the next deep dive.